Good evening. I am Gregory DeMeo, and I am a longtime member of District 3. I have been asked to participate in this COVID panel, and it is an honor for me to be here. I am obviously doing this by video, so I won't be able to answer any of your questions, but you can be rest assured that the staff at ACOG is here to help you with this. My qualifications are such that I have been a member of the Coding and Health Economic Committee of ACOG for well over 15 years. And at present, I am the ACOG delegate to the RUC. It is a unfortunate thing that we have to present this presentation to you during this pandemic. It certainly would be our pleasure to having never had to discuss this, but it is a testament to the hard work of ACOG that this has come together so very quickly. So just to set the ground rules, we should discuss our disclosures. I have no disclosures to discuss. Although, as many have said in the past, I am certain that somewhere in a retirement account, I probably do own healthcare stock. So I think that is important to get on the table. More importantly, my wife has been an employee of Amgen Biotech for well over 20 years, and I think that is important for you to note as well. Please also note that this presentation is for your personal use only. You are not supposed to be using this for resale. Please note that nothing that is presented in this in terms of a product or a procedure means that it is recommended by the college. And most importantly, please note that you should always consult your attorney or an accountant if you feel that there is something that is less than clear. So let's kind of get started with this. Fortunately, we have seen things dramatically change over the past couple of weeks, fortunately to the better. But the fact of the matter is that this is something that is moving on a ridiculously rapid pace. We're seeing governments, state governments get involved. We're seeing payers become involved. Both CMS with Medicare and Medicaid services have become involved. And of course, the AMA has become involved as well. Things are literally changing on a daily basis. What was probably true last week does not necessarily mean it's true today. It all started with an executive order in New York, basically suggesting that record keeping could be relaxed because they knew that physicians were really going to be faced with a dramatic task in taking care of these patients. So for the most part, when it comes to COVID-19 and the stressors that COVID-19 has brought upon the system, the New York governor placed an executive order that allowed the maintenance of medical records to be somewhat eased. Certainly, this does not give you the ability to not be as honest and truthful as possible. But for the most part, when it came to billing purposes, these requirements did become less so. This, of course, opened up some of the floodgates. The United Health Group, being one of the largest, was one of the first to relax these requirements as well. Prior authorization requirements were relaxed, and probably most important for this conversation is the relaxation and the expansion of the telehealth policies. This has become very important, and hopefully each and every one of your practices has been taking advantage of that. Please note that all of these links are going to be available to you either by contacting ACOG or perhaps ACOG will make these slides available to you. So for the most part, Medicaid, an area where many obstetricians participate because of the need, significantly expanded the care that was offered. Federal waivers were immediately put into place. ACOG immediately lobbied for advanced or accelerated payments, and certainly grants for the providers of to the Medicaid population. ACOG and the American Academy of Pediatrics has made this a front page issue, and I do anticipate that we should hopefully see some of grants coming forward to those who do not have a large Medicare population. So telemedicine has really become a significant tool in our armamentarium to help keep your practice afloat during this time. Both the public and the private insurers have advised the increase of telehealth dramatically. The governors are significantly behind this, as well as the American Medical Association. Medicare relaxed many guidelines relative to telehealth, and following suit, commercial payers did the exact same thing. So at this point, telehealth, even for obstetrical visits, is becoming fairly commonplace. In our community, I'm in Wilmington, Delaware. Highmark is strongly encouraging telehealth for obstetrical visits. They are actually providing blood pressure cuffs to the patients, as well as providing dipsticks for urine checking. So in essence, you will want to check with your local payers on all of this, but telemedicine is the big outcome of this unfortunate pandemic. So basically, this is a slide that just summarizes that. I do want to bring to your attention the issues for the suspension of the MIPS program, and that is somewhat important. And the other thing that we'll talk about is easing of the HIPAA rules, which is quite important for us to provide these telehealth services. So this slide, I think, is very, very important, and it has some very important things that are allowing us to operate in the way that we are during this COVID pandemic. For the most part, we're going to be doing the E&M services that we do in our office. So the codes that you are familiar with. Please be aware that your patients can be at home, which is obviously important, keeping them away from any possible infections. And an important point here is that these patients can be new or established. Traditionally, telehealth was mostly intended for established patients, but now CMS is allowing us to do this with new patients. Another very, very important point here is that FaceTime, Skype can be used. It was that telehealth could only be conducted on a HIPAA compliant platform. That is not the case now. The only thing you can't do is you can't use a public platform. So it would not be wise to use Facebook Live. It would not be wise to use TikTok or any of those other similar issues. In our practice, for the most part, we are using FaceTime. Please remember, when you're reporting these services, we are encouraging you to use the exact same codes that you would be using if you were seeing these patients in your office setting. So those codes would be the 99201 all the way up to the 99205. For commercial payers, it was always such that you were using a 95 modifier, and we strongly encourage that you, of course, do that as well. Medicare is actually also accepting the 95 modifier. Please remember the place of service would be the place where you normally saw the patient, so that would be the outpatient setting. This slide is a terribly important slide because it really touches upon an area where we are going for 2021. As you know, the RUC voted on new values for E&M services. These will come into effect in 2021, and these services are going to be based upon time and medical decision making. You can see medical decision making is what we have used in the past, so straightforward, low complexity, moderate or high, and then time-based codes you can see are referenced on the right. These are minimum times and average times that you need to see the patient such that you meet the appropriate code. Virtual check-ins were something that was being used mostly for the review of laboratory studies, patients with chronic illnesses. Many of individuals in our specialty did not necessarily use this, but this now can be used. And you can see those coordinating codes there. Those are HCPCS codes. This slide actually just further identifies the timing that is necessary for you to report the appropriate code. Please remember that these codes were originally defined for telephone only. So 99421, 99441, these were used for the most part for just check-in. At this point in time, we would not encourage you to use this if you are doing what you considered an E&M visit. We would encourage you to use those traditional codes with the 95 modifier. Please remember that this is an important rule, 7-day limitation. This has not been eased. So therefore, if the patient had a contact with the physician or the qualified health provider within the past 7 days, you cannot rebill the patient for the same visit. So the fact of the matter is, if the patient is being seen for a light complaint within 7 days, those visits would be bundled. This is another very, very significant change that came through with this COVID pandemic. And this is something that will assist your patients dramatically. So for these telehealth visits, there is no copay and there's no coinsurance. It would be considered inappropriate for you not to collect a copay when a person is being seen in the office for an E&M visit. So at this point in time, CMS and actually the Office of the Inspector General has suggested that the collection of copays for telemedicine is not appropriate. Please note deductibles will still apply. So when you are seeing a suspected COVID patient, these are codes that should be used. Fortunately, many of us will not be the primary person to see a COVID patient. Many of these patients are being cohorted in such that they are going to special units in the hospital because of the contagious episode of this disorder. So basically, this is kind of a brief algorithm as to how do you appropriately charge for the services you are providing. You can see we've divided this basically from an office visit to a telehealth or a telephone visit. The one thing that's important to note is that telehealth visits traditionally have always been suggested as a video type visit where the patient sees you either through Skype or FaceTime. During this pandemic, however, the relaxation has allowed these visits to be telephone only. So hence the middle of the slide indicating telehealth and or telephone. You can see the telephone codes were the ones that we just mentioned. And then of course, if you had just the check-in visits as well. Please remember, if you're going to be using the E&M service codes, we strongly encourage the 95 modifier. This slide here is probably, again, not something that many of us will be doing. Most of the testing is being done, again, in a cohorted environment. For those, however, who are testing for this virus, please use these appropriate codes, and you can then bill for the service. This is something that is very important as we move down the line towards hopefully immunity. Antibody testing is something that we probably in our office will be doing and will probably be asked to do by our patients. So at this point, these codes are the appropriate codes for determining antibody in an individual who has previously been infected. One of the things that I think you need to realize, if you don't already know this, is that ACOG's resources are huge. They have been very active on this issue, and they have really put together a lot of resources that we can all refer to. These are listed here for you, and you will be able to refer to these if in fact questions come up that need to be answered regarding this pandemic. The other thing that is a huge resource is the question and answer. So at the Health Economic and Coding Committee, we spend usually a couple of hours of our meeting answering coding questions that present an unusual dilemma. So if you do have a question about something that is going on, please send it to us and we will get back to you with hopefully the best information possible so that you can successfully code what you are doing. This brings me to the end of my presentation. This presentation would not be possible without the help of the ACOG staff. I want to especially shout out to Lisa Satterfeld and thank her for her help with this, as otherwise I would have never been able to put this together.